So let me share with you an interesting case. This is a patient with multiple serrated adenomas. Uh, I was referred to resect a large serrated adenoma in the ascending colon, and this patient underwent another Cecal SSA heart snare resection. But when I went in to remove the ascending colon polyp, I examined the scar of the prior resection, and I notice adjacent to the scar there is residual sessile serrated adenoma, as you can see here. This is a little bit tough to resect. Uh, I initially thought whether I should just do another heart snare resection, but because of the folds, I thought that I may be able to lift the lesion and have a little bit of a better margin for resection. So I decided to inject slightly away from the scar, and my injection went well, and there was a nice lift, but as you can see, the scar limited the good lift that one would have seen otherwise. So while I was trying to decide, I thought that maybe I should inject on the other side, and we went ahead and did another injection on the other side of the polyp as well. Again, the lift was not satisfactory. In this case, what I normally do is I go there and try to suck that polyp into my cap to define the polyp a little bit better and lift it up for my snare resection. So I just suctioned here, as you can see here. By suctioning, I was hoping that I could lift it up a little bit for snare resection. In this case, you want to use a small snare because a large snare would not allow you to cut it. So the smallest snare that is available is a 10 millimeter stiff snare. You want to start with a stiff snare because you can position it nicely by anchoring it and then try to cut it. So once we got the polyp, we used EndoCut Q313 for resection, and the resection went well. The polyp was suctioned and retrieved, and then it's always important to examine. And whenever there is scar tissue, it is impossible to be certain that you have completely resected it. And in this case, I felt that I should take whatever is at the edge close towards the scar by using a heart biopsy avulsion technique. So when you use a heart biopsy avulsion technique, I changed the settings from EndoCut Q to EndoCut I. And EndoCut I use an effect of 1 that gives minimal thermal damage. There's not much coagulation, and try to increase the duration to 3. And by increasing the duration, you have a much better, cleaner cut. So as you can see here, we are trying to remove whatever is adjacent to the scar, as we were unsure whether there is a polyp there on top of the scar. So it's important to get rid of it. I'm lifting it, and then I'm tapping on the yellow pedal to get a nice clean avulsion. Following that, you want to examine by getting your scope close by, and this is possible only when you put a cap, as we have done in this case. Although I thought that we resected it completely, I have made it a habit to routinely ablate all resections, especially those where there was adjacent scar, to avoid the risk of this polyp coming back. So in this case, we used forced APC with a forward jet catheter, flow rate of 0.8 liters per second, and with 35 watts as the setting. So we know that the cecum close to the appendix is the thinnest portion of the colon. The thickness of the cecal wall is anywhere between 3 to 5 millimeters in thickness. And when you apply heat for snare resection and also for APC, there is going to be deep thermal damage. And in this case, because of scarring and absence of a good amount of submucosal tissue that would be there otherwise, you would expect certainly a deep thermal damage. And this is likely to have a delayed perforation if we do not close the defect. So whenever I try to do any intervention close to the appendix and I worry about a delayed perforation, I use clips to reinforce the wall and cut down that problem. By doing this, we have not had any problem with delayed perforation, especially in cases like this one that you're seeing. So we applied 2 clips and subsequently resected a couple more polyps that I will talk in the next video. Thank you.